Welcome to Speaking of Midwives, the official podcast of the Journal of Midwifery and Women's Health, where we bring the pages of the journal to life. I'm your host, Melissa Avery. Each episode, we go deep into the evidence, spotlighting the researchers, the breakthroughs, and the midwives leading the science that is transforming reproductive health care. Greetings and welcome to Speaking of Midwives with the Journal of Midwifery and Women's Health. Today, we are talking with Dr. Denise Smith, midwife and assistant professor at the University of Colorado. We're going to be talking about Denise's research and her article published recently in the journal called Outcomes for Labor Induction Compared with Expectant Management Among Women Receiving Hospital-Based Midwifery-Led Care. That is a lot to take in, Dr. Smith, but we are excited to talk about it. Would you please start and just tell us a little bit about your background in midwifery?
Sure. Well, thanks for having me. I love to talk about all things midwives. I have been a midwife for 19 years. I began my clinical career as a midwife in the military health system, first as an active duty midwife and then as a government civilian. I've been at CU for about 10 years now. I'm part of a research lab called Midwifery Reach. My research partners, Bree Thumb and Katie Kissler, and I formed our lab to conduct research at the individual systems and policy levels by midwives, about midwives, and for midwives.
Well, that's great. Thank you. So let's start by asking you to share a little bit about your interest in conducting this particular research. It's very interesting.
We could probably talk the whole podcast about how induction of labor has changed the nature of childbirth in the United States. And I think particularly since the ARRIVE trial publication, the trial of expectant management compared to induction of labor at term, also known as the ARRIVE trial, changed almost seemingly overnight, changed clinical practice in this country. And within our own clinical practice, and I think this is probably a similar experience for a lot of midwives, is there was a kind of an amount of moral distress about what to do with the findings of this study. And philosophically, as midwives, we have a high value on spontaneous labor and birth and the physiologic processes of labor and birth. And to have a large randomized control trial that's findings suggested that induction of labor was like a superior way to approach labor and birth, a lot of us were left wondering what to do with those findings. And in our clinical practice environment, I work in an academic health center. We have a very large clinical practice, which I think we'll talk about in a little bit. We have a research committee, and the research committee was mulling over, what clinical questions are relevant to us right now in this moment. And the induction of labor question always comes up. Is it better? Does it reduce cesarean birth? What does it look like in our clinical practice? And so that was really that driver among the clinicians to understand the phenomenon of induction of labor and how it plays out in our practice was really the driver of the research question.
Wow. So really tied into direct clinical practice. And you said at this moment. That's so important to us and so important to our listeners, mostly who are practicing clinicians. So when you started with this study and were planning it, what was your main objective? Because, of course, you never know what the outcome is going to be. But what did you really want to know when you started this?
Right. So the question among many out there in obstetrics and midwifery is, does induction of labor contribute to cesarean section? And a lot of the studies that compare the outcomes of labor induction are often compared to spontaneous labor. And those studies are very conclusive. Women who go into spontaneous labor are less likely to have a cesarean birth. The originators of the ARRIVE trial and those that did all of the studies, observational and small controlled trials leading up to the ARRIVE trial said, well, that's not actually a fair comparison. the comparison really should be those who were induced and those who weren't induced in that same week. In other words, expectant management, because we can't predict who goes into spontaneous labor. So we can't that's not really a fair comparison. And so by changing how they looked at the groups that they were comparing, expectant management became a comparison group that was more relevant to what you could offer somebody in clinical practice. And so then the question was, well, is the outcome cesarean birth the same if you're offering somebody expectant management, meaning we're not going to induce you, versus whether you're going to be induced? And so that was the outcome that we selected for this study, so that it could be relevant or comparable to the outcomes of the ARRIVE trial.
Okay, that makes sense. I understand. And that's certainly a difference to some of the comparisons that have been done before, as you said. So would you share a little bit about a little more precision? Because I think it really helps to understand how you did the study, before people start to think about the outcomes and the relevance to their practice. So would you share a little bit about how you conducted the study and what you thought you might discover that would, in fact, directly support clinical practice?
Well, one thing that we sought out to do with intention was to replicate a study that had been done prior to this one in an exclusive midwifery managed population. And that study was done by Elise Erickson and colleagues. We replicated the methods of that study with precision. And we can talk a little bit about replication studies and why they're important. But that's how we chose the comparison groups, is that we used the same comparison groups that were done in the prior study. And the comparison groups can get a little bit confusing to folks, like what's the difference between inclusive expectant management and exclusive expectant management? Well, one of the things that probably rattles around in a lot of people's mind when they think about the ARRIVE trial or they think about the comparison group in this study is, what do you do with those who do go into spontaneous labor? Because the expectant management group will include people who had spontaneous labor and birth in either the week of the induction group or the weeks following. And if you think about that, I told you earlier that spontaneous labor has the most beneficial outcomes. It biases then the results toward the lower cesarean birth rate because of the inclusion of the spontaneous labor folks in those groups. So the two expectant management groups either include spontaneous labor for that week or exclude them, just to see if the bias of spontaneous labor affects the outcome comparison for either group. I hope that makes sense.
Well, I was going to ask you to explain pretty precisely about those two other groups. So let's see, how shall I say this? Can you just a little more precisely define them both for our listeners?
Sure. Expectant management. Okay, well, first we'll start with the initial comparison group is induction of labor.
Right.
And so the induction of labor group includes each individual who was induced in that respective week of gestation, starting at 37 weeks, all the way through 41 plus weeks. The expectant management group broadly is everybody else who wasn't induced in that week and then goes on to remain pregnant and either go into spontaneous labor or be induced at a later gestational age. Within the expectant management group, then, there are two subgroups. One that's called inclusive expectant management. It includes those who go into spontaneous labor in that same week as the induction group, and the exclusive expectant management group that excludes those who went into spontaneous labor during that same gestational age week as the induction group.
Okay, so for that group, then might they have gone into spontaneous labor the following week?
Correct.
Okay.
Yes. Right.
Okay. All right.
So it just just tries to account for the bias that can happen.
Okay, that's great. All right. So one of the really interesting things to me about your study that I assume you would think is a strength, that seems like a strength to me, is that you have 4 different kinds of midwifery practice groups at the University of Colorado, and you included them all. So you had 4 different groups, which gets you beyond what people often start out with, a single group. It's how we start out, but you had four. Can you talk about the practice environment in those four groups?
I can. And I think it's a strength of the study. You can say, a single site study can just be about that single site. Um, but in our practice environment, of course, our main clinical practice groups are practice at our academic medical center. And in that, there are two of those midwifery practice groups practice in that same center, but have a little bit of have different practice models. The largest group of those is what I would call kind of a public health focused practice group. The academic center is a safety net hospital. It's one of two safety net hospitals in the greater Denver area. And that practice group cares for a lot of the patients that receive care in the safety net hospital. The other three practice groups, including the other group that is practices at the academic medical center, are more, I'm going to say, stereotypical midwifery practices where patients are seeking out midwifery care for a particular reason. And two of those groups practice at community hospitals in the northern suburban area of Denver and the southern suburban area. So across those four practice groups, then the sample becomes a lot more economically and racially diverse, and therefore more representative of the population as a whole. I also think it's important to point out the different practice models because a lot of people are concerned that studies about midwifery care really have a lot of selection bias, meaning that, well, the patients included in this study are seeking a particular type of care. So they have a particular motivation or desire for birth that tends
risk profile.
Right. That, of course, they're going to have, spontaneous labor and birth, or of course, they're going to have a vaginal birth. All those people want those outcomes. And so I think the diversity of the practice groups and the populations in them are more representative of the type of people that would get care from a physician exclusive group as well.
Yeah. And then just to clarify for our listeners, this was an examination of records. Is that correct?
Correct. We used electronic health record data transcribed into a data registry or our own database, so to speak. Originally, I think a lot of practice groups across the country send data into our professional association's benchmarking activity. Once upon a time, that was the origins of the data set, but about almost 10 years ago, Jessica Anderson and I, who was our practice director at the time, conspired to really take the data set up a notch and to really have data that could be used across for multiple purposes for quality improvement and to do research studies just like this. So one of the lovely things about having this data set is that it's curated, so to speak. The data is put in by midwives, so it's very specific and has a lot of data points that maybe an electronic health record might be a little bit harder to retrieve.
Well, and the people who are providing the care and attending the birth put the data in as opposed to somebody who doesn't understand midwifery practice.
Correct.
And some of the nuance. Yeah.
Right.
Okay. So what were the main outcomes? What did you really want to know? What was your main outcome or so of this study?
So going back to talking about the ARRIVE trial and all the induction studies does induction lead to an increased rate of cesarean birth? That was primary question. And the outcome was no. In these comparison groups, there was not a statistically significant difference in cesarean birth outcomes in the induction group compared to both expectant management groups.
Okay. And I'm just going to add, as I recall, reading the article again, in the hands of midwives.
Yes? Correct. That's, I think, a very salient point is that these are 7,000 plus midwifery managed and attended births. So this is midwifery clinical management during the induction all the way through process. Of course, the cesarean birth is conducted by a physician, but the decision in these four practice groups, the decision for cesarean birth is made by the midwife. So, and And I think that will become important as we talk about, why we think and what the implications are is, why midwifery managed birth is an important part of it.
Yeah, an impressive data set to ask these questions. So what were some of the other more secondary or, other smaller outcomes that you took a look at?
Sure. So, replicating the Erickson study and other similar studies on induction, we kind of went through the laundry list of secondary outcomes. Birth weight, infant birth weight, postpartum hemorrhage, APGAR scores, NICU admissions, tried to look at kind of this whole balanced set of outcomes. And then we also collected, which I think is very salient, is the time that the patient spends on the labor unit.
Mm-hmm.
And so, and just to kind of get ahead of you, few of those outcomes were statistically significant in their difference, with the exception of postpartum hemorrhage. The group that was induced at 37 weeks had a significantly higher rate of postpartum hemorrhage. Of course, if you think about the clinical management of inducing labor of somebody at 37 weeks, that kind of is a natural expectation that they might have a higher rate of postpartum hemorrhage. But the length of time spent on the labor unit, the time from being admitted to being delivered, was wildly different across groups. And we included the induction group, the expectant management groups, and we also parsed out spontaneous labor in that group because I think that if you've been around folks who are working in hospitals these days and you bring up induction of labor, the first thing that comes to mind is the overwhelming volume, demand for getting scheduled for the induction. I would say some of the jockeying that goes around and the manipulation of providers to get their patients onto the schedule for being induced, and forcing hospitals and nurse managers, charge nurses to come up with their algorithms for deciding who has priority. I mean, it's become its own little rat race of sorts to see what happens. But along with that, I think you're hearing, anecdotally from folks that their units are full of people being induced. And interestingly, in the ARRIVE trial, the studies that followed their secondary analysis, they were trying to make a case for, resource use, that being induced uses less resources than, somebody remaining pregnant. Well, the question is whose resources, right? Is it resources in the outpatient setting outside of the hospital, or is it resources inside of the hospital? And I think this is pretty conclusive that these patients are just spending a lot more time in the labor bed.
Right. And so that uses hospital resources, as you said, but for people with other children, their jobs, I mean, it has tremendous impact on resource use outside the hospital, doesn't it?
It does. And, one of the salient parts of this study, and I think it's important to consider, is that, some people need to be there more than others. And we want to be egalitarian and, talk about equity in the sense, but I think it's really important that some people need medical management at the end of pregnancy and
Absolutely.
others don't. And it's how you see, resource allocation in those terms, I think that is a bigger question.
Mm-hmm. Yeah, excellent point. So what are your primary implications for clinical practice? What do our colleagues need to know based on your work?
Sure. So I'm going to go back to the original driver, the people who wanted this question answered, and those were the clinicians in our clinical practice. And one of the questions they had, of course, that was driving, does induction lead to C-section, is how do you appropriately counsel a patient who either has a medical indication for induction of labor or who is asking for a term elective induction? And I think in terms of informed consent and shared decision making, being able to provide the person sitting in front of you with relevant information on what they can expect for a clinical outcome is important. And especially in the setting where they're going to be managed. It's one thing to, in your shared decision making with a patient, to cite a randomized control trial. that was done in 12 academic medical centers where they have 24/7 in-house physician management, right? When you're sitting in a community hospital where the provider is remotely managing the labor induction, what are the clinical outcomes in those environments, right? So being able to say to a patient, well, if you develop gestational hypertension and you need a labor induction at 38 weeks gestation, in our center, if managed by our providers, your likelihood of a cesarean birth is not increased. And I think that takes some of the fear component out of it, like, oh, I don't want to be induced. I might end up with a cesarean birth. I think this gives the provider the right amount of information to inform patients of the risk for a particular clinical outcome.
Right. And you talked a little bit, you told us earlier about designing your trial, your study, similar to Dr. Elise Erickson and the one she did at two different sites, correct?
Correct.
I think they had two sites. So will you talk a little bit about your outcomes compared to theirs?
Well, first, with the replication study, like why redo a study that's already been done before? Well, one is that if you don't have a lot of money to conduct a randomized control trial, one of the ways of validating the findings of a study is to repeat the study in a different setting and see if you get the same outcome. We shockingly had almost nearly identical outcomes. The incidence of induction was 28% in that study. The cesarean birth outcomes were quite similar. The non-significant difference in findings was also the same as the Erickson study. And so I think the conclusion that you can draw from that is that in patients receiving midwifery care, this is probably a generalizable finding to these similar settings.
Yeah, very, very impressive. Very impressive to be able to make those comparisons and, as you said, replicate and have similar results. Do you see policy implications from your research?
I sort of.
And by the way, I don't necessarily mean changes in legislation, but policy happens, at the system level and practice as well as more broadly.
Right. I think there's actually, if you think about policy, kind of on a multi-level, like in a socio-ecological model, probably the biggest implications are organizational and unit level policies and practice level policies. And, if I were a health systems leader making policy for a health system, and I looked at data like this and looked at my staffing models, and, I probably would try to rein in, induction of labor, wild induction of labor practice, right? So that you didn't have a list of 17 patients waiting to be, called in each day. And then similarly, I think there are some policies that guide hospital unit leaders in the moment, especially. If you look at, the gestational age differences on the length of stay, there's 30, and I think a lot of people probably know this by experience, 36 hours, 24 hours, in that labor induction process. That's a significant amount of time. That's a significant amount of nursing staff. And so I think there's information there that can kind of drive the bed acuity, staffing levels, that kind of thing. At the practice level, and I specifically am talking about midwifery practice, they're probably coming to some level of decision-making and consensus on how you approach labor induction. One of the things, I think one of the takeaways from this, if you look at the medical comorbidities of the patients in this sample, there's a significant amount of hypertension and other comorbidities that really support clinical management for the end of pregnancy induction. Mm-hmm. And kind of getting your brains around, like, people with hypertension need to be induced. And if we're going to induce people, then we need to do it well. And, so that we can offer them the best clinical outcome for that situation. So I think it's policy directly related to clinical management in the organization of care.
Okay, thank you. So we have to ask the research question too. What else do you think is needed? Maybe you and your team have some plans for the next step down the road since this just got published.
We do. In fact, our research group, our committee is still meeting, and we have just formulated our next set of research questions that will go to our institutional review board probably in the next month or so. One thing that, when we shared these results with the entire clinical practice, there's almost 40 midwives in this clinical practice group, and sharing these findings, is a lot of people were pleasantly surprised. Some people not pleasantly surprised. They were, I think the bias is that, we wanted it to be different, so that we could discourage people from induction. I don't think that's, particularly helpful, but then the next question was, well, how is that possible? The why, what is happening kind of question. And so we're kind of using a framing of positive deviance. If you have this clinical environment where you have a good outcome, what are the steps leading up to that good outcome? And so we're going to take a deep dive on the decision-making and clinical management of labor induction across these 4 practice groups. How do you approach it in making the decision with a patient to induce labor? What goes into your initial thought process and counseling when making the decision on how to proceed with induction? And in some of these they have different staffing models, call models versus in-house models. How does the interaction with the team, like you have multiple people across time managing these longer labor inductions, what's that interaction like? And we're kind of calling it the recipes for induction study. What does it end up looking like on the other end? Like we're saying, if this is a clinical practice where you have good outcomes, what are they doing that leads to these good outcomes?
Sounds interesting, and we'll look forward to the results. So as we kind of come to near the end and sum up, what would you really like the listeners to know in a nutshell about your work and our discussion today?
I think one of them is not to be afraid of labor induction, and but to appreciate it for what its intended purpose is, and that it doesn't negate the value that we see in physiologic labor and birth, and that treating each patient as an individual and arriving to a decision on whether to induce labor, like if you're considering elective induction based on that particular person's needs and desires. That I think knowing your own practices data, how well do you do birth? Are your vaginal birth outcomes in a good place now? Because induction probably won't improve that. It could make it worse, but it probably will be the same. And so maybe doing a deep dive on your own clinical practice data and understanding how you work in your environment.
Great. Thank you so much. So now here's the hard part. Can you provide our listeners with one final sentence summing up what you want them to know today?
The drivers of cesarean birth are probably more about the clinical practice environment than it is about the induction itself.
Okay, I think that's interesting for people to think about as they turn their car off or head to the next thing they're going to be doing on their day. Well, thank you, Dr. Smith, for a really engaging conversation and for participating with us today on Speaking of Midwives. And for everybody else, we'll see you next time. Thank you for joining us on Speaking of Midwives, brought to you by the American College of Nurse Midwives and the Journal of Midwifery and Women's Health. If you were inspired by today's conversation, connect with us through ACNM's channels. The Journal of Midwifery in Women's Health is at jmwh.org, your resource for cutting-edge midwifery and women's health research. See you next time.